Thanks, Dr. Mukesh. I think we just had a very interesting session on refractive surprises and how to manage them. A common situation where that would arise is what we're going to discuss now. So, why is special attention necessary after refractive surgery in case the patient develops a cataract? Is it because it's very difficult or it's out of the ordinary? I think it's because it just requires a little more understanding and care than our routine patients. Patients who undergo refractive surgery in the first place do so because they don't want to wear glasses. So when the patient comes to you for cataract, to tell him that, okay, you might need to wear glasses after cataract surgery now, needs to be tackled a little bit carefully. The issues in cataract in these patients not just pertain to the IOL power calculation and the errors that would arise there, but also the induced aberrations from the refractive surgery and how that would affect the quality of vision. And counseling these patients before surgery, what to expect, how you may need to tackle the refractive error after the cataract surgery. So I think all of us, I think it's not our favorite topic. We hate it because it's seemingly complex, unnecessarily time consuming. A lot of scans have to be done. You have to scratch your head a little bit. We've all become doctors because we hate math. It's anyways a little bit of trial and error and instinct at the end of the day. Do I really need to know this? I mean, I'm going to get one patient in probably 6 months. So is it really that common and important for us to spend that much time? But I think with the number of LASIKs that are being done these days, we're going to face a tsunami of these patients, maybe like 2 decades from now. All of them with cataract. I think we're going to have more patients than we can imagine. I'm going to start with a seemingly ordinary case. A 55-year-old patient walked into our clinic wanting cataract surgery. Everything seemed perfectly fine. The vision was 6/12. The surgery was uneventful. But the day after the surgery, the uncorrected vision seems less. The ARR is showing okay, plus 1.75 diopter error. You say, okay, maybe just give it a little time, call the patient back a week later. The error seems the same. Patient is not entirely happy, but I think you are unhappier than the patient. So you go back, look at the biometry, the scan seems fine, but okay, the K values seem a little flatter than what you're routinely used to seeing. So you go back, fingers crossed, and there it is. You see what you've missed. The puzzle is solved. There's a flap, LASIK flap that you've missed. So in these patients, getting a good history is very vital. Most of them will be forthcoming. They'll let you know that they've had some refractive procedure, but a small percentage may not know the significance of it and may not be forthcoming. And if you don't, you're not alert, if you don't catch the flap or you don't notice that the K values are 39 or 40, you may just miss and land up in trouble. So in these patients, try to get a history of the procedure, any details available. Ensure that the refraction is stable, especially in cases of RK, where it may be a little fluctuating. Make sure that you counsel the patients well. Tell him that it may not be entirely bang on the biometry, but you'll do your best. A topography, I think we're going to discuss in detail, is absolutely essential before planning cataract surgery. So I'm going to start from the start. IOL power calculation is determined by 3 factors: the corneal power, the axial length, and the effective lens position. I think we hear this term commonly these days. Out of the 3 factors, the only thing that we directly measure is the axial length. The instrument will measure the axial length. The other 2 are derived from something else that we measure. And this process of derivation is where we can go wrong. So the cornea actually has an anterior and posterior surface, like we all know. So the corneal power is the sum of both. It's usually expressed in diopters, the dioptric value, but what we measure actually is the radius of curvature. So the radius of curvature is measured and then converted to dioptric power. The conventional techniques of corneal power measurement, the keratometry, measures only the anterior corneal curvature. It ignores the posterior corneal curvature. It assumes that the anterior posterior have some kind of normal ratio and relationship, and based on that, it will derive the total corneal power. That too, it doesn't measure the central most value for the corneal power. It measures like a 3 to 4 millimeter paracentral zone. So the actual central K may be a little bit different after refractive surgery, maybe not that much in normal cases. And then, as I said, the radius of curvature is converted to dioptric power using a constant value, which again may be a little faulty after refractive surgery. So this is just showing that after refractive surgery, The value in the 3-4 millimeter zone may be around 40, 39, but the central value 36. So if you go with the conventional values, you may actually grossly overestimate the corneal part. The central may be much flatter than what your device is telling you. Again, as I said, the relationship between the anterior and posterior curvature and the index of refraction, the conversion factor varies after refractive surgery. After LASIK, PRK, with flattening the anterior surface of the cornea. So that flattening causes an altered relationship or ratio between the anterior and posterior surface and a change in the refractive index. After RK, the anterior and posterior surfaces are flattened. The error post-RK is not as much as after LASIK or PRK. Using standard devices, the error may be a little bit less, but there are peculiar features after RK. The refraction, the K values may show quite a bit of fluctuation diagonally over time. Also, after cataract surgery, you're bound to get some kind of hyperopic shift. It may take a couple of weeks to stabilize after RK. So as I think the conclusion is that our standard devices may overestimate the corneal power, and that results in a post-operative hyperopic surprise. The other fallacy of conventional corneal power measurements, that it assumes that the cornea is a spherocylinder. It assumes it to be of, the irregularity is not considered. Irregular astigmatism is not considered and missed, especially if the refractive surgery had caused a decentered ablation or there's a central eyelid. Irregular astigmatism is not that uncommon after refractive surgery, and that may not be considered or accounted for with standard devices for corneal power measurement. So manual keratometry, auto K may not be good enough. You definitely need to get a topography done, and not just any kind of topographies. Hopefully systems that will measure the anterior as well as the posterior corneal curvature, and that take into account the corneal thickness. So both surfaces considered, and then I think most of the systems give you, there's a wide range of maps available. I think Dr. Karishma is going to touch upon that in her talk. So you have to know which map to select. Don't just go with the conventional 4 maps that you're seeing. You may need to, dig a little deeper, find exactly what values to choose for IOL power calculation. So now more and more tools available are not just, we may not have access to the ISIS and the Humphrey and the Atlas and the Galilei, but I think we still may have access to the OpScan or the Pentacam or the IOL Master, and there are more and more tools available now that we will be discussing that can use these values. The second erroneous factor after corneal power is the effective lens position. The effective lens position relates to the place where the IOL is placed. It depends on the anterior chamber depth and the corneal shape. So after refractive surgery, when your cornea is a little flatter, if you enter flat values for the corneal power in the formulae, they assume that the cornea is flat and the anterior chamber is shallow, and so your IOL is anteriorly placed. So this is one fallacy. It assumes a position of the IOL where it's not directly measured. So what happens is, after refractive surgery, the IOL is assumed to be positioned anteriorly, and that then the formula would give you a lower than desired IOL power for the same eye. So instead of going with a 20 diopter, it will say 19 or 18, because it is assuming that your IOL is positioned anteriorly because of the K values that have been entered. So as I said, this just to sum that up, it assumes that the IOL is positioned anteriorly, and so it underestimates the IOL power. That would again contribute to a hyperopic postoperative error. There's a relationship, as I said, between the effective lens position and the K value. The K value itself is inducing an error in your calculation, but the K value is also used to calculate the effective lens position, and so it's doubling the error that it induces. So there's a compounding effect of the error induced by the corneal power. The effective lens position error may vary with what formula you use. It's maximum with the SRKT formula. It also varies with the amount of LASIK correction and the axial length of the eye. So I think Aramberri came up with this brilliant idea of using the Double-K method. What does Double-K mean? That you're using the pre-refractive surgery K to determine the effective lens position, and the post-refractive surgery K to calculate the IOL power. So since the K value, even if you don't have the pre-operative K value, you can still use a standard value of 43.86. It gave much better results then using the post-refractive surgery K value in twice in the formula. I think that it will be discussed better by Dr. Karishma, a little more detail. But coming to irregular astigmatism, as I just mentioned earlier, it's not uncommon after refractive surgery. Not necessarily decentered treatment, central islands, but patients usually do have some cylindrical power remaining after refractive surgery. So on topography, if you realize that it's irregular, there's some kind of striae, the center, it's decentered. So is toric IOL the only option available? Because I don't think you can do any astigmatic, any femtosecond arcuate cuts. These corneas may already be a little weak. So here is where you can consider, if it's grossly irregular, you can actually consider a topography guided treatment of the cornea before calculating the IOL power and taking the case forward for cataract surgery. So that's what we call corneal customization before cataract surgery. Just to illustrate, the first image, the one on top, shows a decentered ablation, and on the right side is the corresponding quality of vision for that patient. The patient had developed a cataract, but we realized that the ablation is quite decentered. So we went ahead and did a topo-guided treatment for the cornea, where we kind of regularized the cornea. The quality of vision seems much better than that, and then follow it up, say 6 weeks later, by biometry, and then a cataract surgery. Other than irregular astigmatism, another common issue in post-refractive patients is the higher order aberrations. No matter what, LASIK, PRK, RK, it all affects the corneal aberrations. It causes them to become quite erratic. That usually translates to night vision photic phenomena. The first image shows if the coma were to be specifically high, this is how a street light would appear to the patient. If the spherical aberration was specifically to be quite high, this is how it would look. And the third shows if the trefoil was high. So usually it's a combination of these factors, and that would persist after cataract surgery. So the main culprit usually is the spherical aberration. After myopic LASIK treatment, the normal spherical aberration of the cornea is about plus 0.26. It goes towards a higher plus side after myopic LASIK. The cornea is flattened and it would increase. So this is a split up. This OPD scan 3 image actually gives us a split of the total ocular aberrations, the corneal and the internal optics. Here we see that the measured corneal spherical aberration after myopic LASIK is almost 4 times the normal. And the opposite would happen after a hyperopic laser surgery. The cornea is kind of steepened in the center, so it tends towards a negative value. So the measured values here, after hyperopic surgery, it's become minus 0.6. So it shifts quite a bit from the normal. So now the step towards this is, we have devices that will measure the patient's spherical aberration, corneal spherical aberration, and would actually recommend what kind of IOL is suitable for that eye, depending on the measured spherical aberration. So this again, the OPD scan 3, it would actually give us the IOL that should preferably be implanted to not, enhance the altered spherical aberration. So after LASIK, after myopic LASIK, since our spherical aberration is quite on the positive side, you can either go with aspheric lenses, like the actors of IQ or the Technis, depending on what measured value we've gone with. Or after hyperopic treatment, you should probably go with positive spherical aberration lenses to counteract the negative spherical aberration induced. So this is just like a small step into what the future may hold. It's definitely not, we're not coming with the zero spherical aberration after cataract surgery, but with light adjustable lenses, if that's going to be the future, we can probably counteract the corneal aberrations induced with some lens treatment after cataract surgery. This is just some food for thought. So can we do multifocal IOLs in these patients? Probably you can if the treated error is small. If the cornea seems symmetrical, regular, the aberrations are not too high. If the treated zone is not too small, you can still consider a multifocal IOL depending on the topography, the aberrometry that you've seen. It's best to avoid it in highly irregular or aberrated corneas. If there's ectasia or decentered ablation, it will have a multifocal lens needs to be centered, the cornea needs to be regular, definitely. So to sum up, after myopic refractive surgery, the tendency is towards post-operative hyperopia, and just the opposite. After hyperopic surgery, the tendency is towards post-operative myopia. So the take-home message is counseling patients is vital and downplaying the expectations as to the best of your ability. Topography, not just to measure the central cake, but to rule out irregular astigmatism. Modern third generation formulae preferably to be used, not regression formulae. Go towards the highest value for your implant. If the calculation is saying 20 with a range of 19 to 21, go towards 21. Don't go towards 19. Go for a higher value to avoid a post-operative hyperopic surprise. And take into account the quality of the patient's vision, not just the numbers for IOL formulae. I think with that, I would thank you for your kind attention. I'm going to invite Dr. Karishma to come forward to discuss the tools available at hand to handle all the problems that I've just discussed.